This conference will now be
Good evening,
recorded.
dear colleague. Welcome to the live session of the Online Cardiology Club with international participation. I am very honored to be joined by Dr. Vidal-Perez on tonight's meeting. As a brief introduction, Dr. Vidal-Perez is working as a cardiac imaging consultant at Coruña, Spain. His interests include cardiovascular imaging, e-cardiology, and cardiovascular disease prevention. He has worked as an active member of communication committees of several ESC associations. And I'd like to welcome Dr. Vidal-Perez once more.
Thank you for your presentation.
As you all know, statistics have shown that half of the world population is using social media in the world, and cardiologists are no exception, sharing, disseminating the information, and interacting. I believe these three are the three key points that keep us engaged with the social media. Tonight, Dr. Vidal-Perez will be presenting us about the impact of social media in cardiology. This will be followed with a Q&A section, where I'll be addressing your questions and comments to him at the end of his presentation. So please feel free to write down your comments and questions at any time during the session using the chat tab, which you may see on the upper right-hand corner. And the stage is yours, Dr. Vidal.
Okay, so I start my presentation, no?
Yeah, sure, okay. Thanks.
Well, so I will share that part of the screen. Well, thank you first of all for your kind invitation. It's a pleasure for me to speak about this topic because it's a topic that we're very involved in different aspects, because I am involved on the social media of my society in Spain. And I was also previously involved also in Jack Case reports of social media editor in the last year. So I know more or less the importance of this topic. I want to thank you, Duygu, for this invitation for the Online Cardiology Club. I hope you learn something, or at least you create a social media account. This is my end point. It's not so big, but I think you will enjoy it. In the point that you join the social media, you will get many things that are there, and I think they are useful for any cardiologist, as I will try to show you in this presentation. I have no conflict of interest with this presentation. Only I could say that it's about loving technology. Some recognitions, many materials come from the Spanish Society of Cardiology. I have been working there for a long time, and also from the European Society of Cardiology. I have to say that also Twitter, it's a good place to find information, also Google. So I think you have to recognize all these sources of information. But this is one joke that I will show you, but listen to this message from Yoda, from the Star Wars film, and you will understand. Well, I think it's important message that Yoda shared with us, that is as cardiovascular specialists, do we need social media? That's the question. And the answer that Yoda says is, I think it's in this moment, there is no try about using social media. I think you need to be involved on that. I think there is no option. It's do or not, none. I think it's something that you have to do. Because it's a thing, first of all, I think it's the perfect way nowadays to stay updated, and I think everything is there and in the first second. So I think it's something useful for everyone. So in a summary, I will show you how it's more or less in the digital world, where we are now, what happens with the patients and the physicians. Do we need social digital tools? And at the end, do I need social media? That's the one of the main questions. So if I will try to show you now where we are now. In this current moment, probably we are like these people that they are lost on this side, but at the end, somebody is seeing us through Google Street View, as they say in this joke. So at the end, it's very difficult to be not connected to the digital world. As you know, a lot of people is in the digital world. We have a lot of media users. In some statistics, 50% of the world population is in some social media. this digital thing have effects over on the jobs, and it is important because there is a digital revolution at the end. And if we check other aspects, a lot of people is using health and fitness apps, like 26%. I think the next talk will speak about some of these aspects. But if you check social networking apps, are near 90% of the people. Maybe you don't have a professional use of the social media, but probably it's a possibility that your social media could help you on your professional life also. So I think the point, I think it's important. The world before social media could be in the left. You have a lot of things on your table, the normal telephone, photographs, some things that you check your contacts, photograph, and that changed a lot because you can convert in the last years, as you say, we have converted all the things that you have in your desktop to a computer, and at the end probably this computer is your smartphone, because a lot of things are in your smartphone. You can check in less than 10 years, as this tweet says, many of these things are in your smartphone. And you can know that the digital world is moving so fast when you think even in 14 years ago, all these things were not in the world and are everywhere now. So the digital world is producing a lot of things in social media, but on other aspects. As you say, here is nice information, how many things are produced in the digital world in only 60 seconds. If you think in social tools, probably these are the 5 more known for now. They have different uses, as you see in the columns. Pinterest probably is more about things about fashion or furniture, but probably for professional things, you have Twitter and Facebook currently, or LinkedIn, but in a different way. Probably the most powerful tools are Twitter and Facebook, and some people is using Instagram, but probably Facebook was more used for different reasons in the past. Twitter maybe could grow a little more, LinkedIn, but the main point is that many people is how to say, browsing things through the mobile phones and tablets. So it's more, the accessibility is more handy. You have very easy access, more easy access to things. You think how many time do you spend on using digital things? In these graphics, I think it's very clear that many of the access to many things now are doing by the smartphone through apps, or even access to the web through smartphones. Desktop is less used with the pass of the time. And if you check this statistic, is coming from Spain, it's written in Spanish, but WhatsApp, I think every one of you know it, and they say how many hours you use it during the week, like 5 hours. So it's something that is used a lot, but you can say Twitter 2.5 hours in 1 week. So I think social media, you have it in your apps, you have it in your mobile, it's very easy to use. So we can think how to deal with patients. Probably we will need to deal with patients with the social media, and we have to ask, instead of the phone number, what is your social media data to contact with you. And anyhow, you have everything in your smartphone. You can see that that man that is like a Martian, it's waiting for the train, is the only one that does not look into the smartphone. That's the way how we deal now with technology. You are really connected every time. And we reached 2010, we have this coronavirus pandemic, and probably it will lead us to use more digital tools. So I think it's good to know the social media tools in this point. How we deal with patients and physicians. I think there was a change in the last years. I think it's also important when we thought in social media. For example, we were learning like this, a lot of people together. Now this is impossible. Our job doesn't change, as you read in the right. What is the job of a physician? Somebody gives you money or a salary, and maybe you get healed or not healed. So it doesn't change, but probably it changed how we learn things. Probably that's a picture from the left is impossible to be done in current days. So also how we deal with patients. Now we deal with the screens instead with patients. This is something joking, an emergency physician, but at the end we are like treating computer screens. Also the medicine could be through Uber, who knows? It's something different. And the medicine is changing. If you have Twitter, I suggest to follow Eric Topol, that went from how to say, interventionalist to genetics and technology. It's a guy that is nice to follow if you want to be updated on technology. The new medicines have changed how it works. You have many things through the phone, digital medicine. I mean, even also how to use your smartphone could be used for doing things like an echocardiogram. Probably your smartphone could do more things. So we are moving in a technology wall. The back of the doctor have changed also. You have tools to do DCG. These are topics that probably we will know in the next lecture. And also the echocardiogram could be done by the smartphone. And our patients are more prepared. That is another point. And they want to deal with us probably on social media. Maybe now you have to be more prepared than them. It's another joke. Probably you need more speed than your patients to be updated, because a specialist patient sometimes knows more than expert, because it's always focused on his disease. You know that a lot of people look for things on Google. So the scientific society needs to be ready to provide content. This is an example from the Spanish Society, but the European Society has content also for patients with heart failure. So you need to be prepared to give content to the patients through web pages or through social media. For example, Heart Failure Matters has also a Facebook page. So digital tools, I think it's everything clear that it's everywhere. If you think this photo is coming from when the last Pope was elected, Ratzinger, nobody has a mobile, only that guy. If you check what happened in 2012, it's completely different. The world has changed how to use the technology. Even if you make a photo, you don't do it in the way that you do it. You do it like a selfie. So these tools are in your phone. In your phone, you can have your social media tools. So I think it's something that could help you even in the daily life of the cardiologist on your practice. And you touch a lot of time the phone for doing a lot of things. And this landscape is still changing. This is 2013, 2017, even more things on social media. Maybe the biggest are these that you see here: WhatsApp, Messenger, Facebook, Twitter, but Instagram. But there are a lot of things available. So the digital tools, I think they have a lot of benefits. I will speak later on also on education. You have a digital identity that you can promote through your social media. Probably some tools help you to do a more efficient working. Maybe it's a tool to give patients a better patient education. Probably the patients could have an improvement of their experience. And why not also generate knowledge with this data? I think there is opportunities on that. So we are moving from this 1.0 web that was more, you publish something and the people is listening, and now you have something that is more with sharing. You do content, you share content, you give. So it's completely different. And probably there is no change, but the change is how we do it. And now it's that we have some immediacy, ubiquity tools that is your smartphone. So it's very easy to share and to be updated. You don't need to go to a library or something like that. It's something in your phone. So if you think in the doctors or physicians or healthcare workers, at the end, we are managing knowledge. And there are many ways to get information. You have blog, podcasts, wikis, social media, and we are using applications. So you have instantaneous access to the information. It's cheap, it's direct, it's not invasive, and you can create opinion even. So this social media or the email, your smartphone are creating new roads for communication. So I think we need to be at least prepared on using these tools to direct contact with patients, with general population, or even with your peers. These are one of the things that we can get. Of course, these advantages also have problems. I have to highlight too. Infoxification is a big one, because you get a lot of info and you don't know always that it's true or not. It's complex. So you have to choose which are your sources of information, and you probably will have good information if your sources are good. How to say? Other problems that we have is online reputation. This is something professional. It's how to say, spare time of professional time. Some people say that it's something that is not well recognized. Other problem is you are always connected, so it's good, it's bad. So If I go to one, I need social media with examples, we can think on cardiology. This is from 2015. In a survey, only half of the cardiologists say that they are using social media. And mainly in this is US, 20% of them say only for professional uses. So which tools? LinkedIn for professional networking, or 30% Facebook, YouTube, even Twitter, I think for obtaining information. That's one of the points. The problems in red: privacy, not enough times, could have implication on practice. So we can still think, is this something for freaks or it's useful? Okay, social media is here, it's in the world, and it's part of the world. So the problem is if you have it or not have it, is if it could have impact on how you are doing things. And the challenge, I think, is applying this with criteria, if it's something useful for your tasks. For example, if you think in a professional point of view, I think it's something that allows you to access and share health information in a massive way, and also to communicate with professionals. Scientific journals, scientific societies are on social media to give updates. It's because it's very easy to get there. So you have to choose one social media. It depends what are you looking for: to reinforce communication with your colleagues, to increase the visibility of your brand, your work, your research, traffic to your blog. It depends on your interest. This is one example. This is from the Spanish Society. If you see here, there is a bar with all the social media tools that we are using in the Spanish Society. You can see that there is a lot. We have a well-prepared web page, but we have also this, that is the Twitter account, the YouTube account, the Facebook account, because we want to stay connected with our members. When we do some kind of the education event, we promote it through the different social media sites. We use YouTube to stream, Twitter for interaction, SlideShare, we share our slides, we call the people through Facebook. But if you think something bigger, like in the ACC, they share this slide that is interesting. The different social media tools could be used to communicate with patients on different ways. So it's something that you need to know. Another point, your online reputation. Maybe it's better you control your account than somebody speaking about you. So it's good to have your name there and have all the things controlled by you. So I think it's something that is not optional. It's part of your responsibility to, how to say, control your social media accounts, or something that it could be created with your name. If we think in learning things, we have Facebook, for example. You have a lot of learning opportunities on Facebook groups. I think many of you know it. You are inside them. You can let a lot of cardiology there. But for me, honestly, I think the best app is for many things it's Twitter, because you can interact with your peers. You are in permanent update. You have learning opportunities. You can share knowledge. Probably you have to pass different Twitter states of use. At the beginning, you don't believe that this could be useful. Maybe you start to have some curiosity, then you discover this is useful. There are many people that stay in this obsession phase, and then some people that could live with Twitter and continue their life outside Twitter. That is something very important and healthy, I think. There are many magic words that you have to know about Twitter: the tweet, retweet, timeline. You can check about that. The hashtag, it's important how many characters you can use. Now they passed to 140 to 280 in the last years, but it could help also for science publication and communication. This is an important point. I have to say also that you say the hashtags there have a lot of engagement. You reach a lot of people. You can see thousands of people can read the tweets, how many people is participating with the different hashtags. So something that it could be nice to follow. This is an example about a Congress. You can see that the ACC 70 generates like 60,000 tweets. This is important. Well, it's something that gives space for your Congress. You can see AHA, ACC, ESC, they do a lot of tweets. So there are many publications. I recommend you this to get on the language. What is the analytics of Twitter in cardiovascular medicine? That it's in Jack Case report. That is interesting. Some people speak about impressions, retweets, but I think the main impact is how many people read what are you writing on social media. If you see how it's going on conference, you get more users, more tweets, less physical attendees, but you have a lot of people following the Congress through social media. So I think it's something that it's getting useful. Even in a Congress, if you don't allow to share things like it happened in this diabetes Congress, then the news is that you don't allow to share. Even nobody cares about what's happening in the Congress. The people start to discuss, you are not allowing people to share content in your Congress. And another point that is important is probably that the impact of tweets on citations. There were some evidence on that. People think you, in the editorial world, you think, okay, put something on social media, there are metric scores that are things that measure the impact of some social things. And at the end, probably it could go through citations. And I have to say that there are some works, publications on that. There was something recently in the European Heart Journal that we demonstrate the effect of social media on the, the prediction of citation rates. It was a study that we randomized papers to active promotion or not. And at the end, you can see here that you get more, even if you have more impact on social media, it correlates with your number of citations. It's the preliminary data with 600 papers from the European Heart Journal, but at the end is if the people speaks about your paper in social media, probably the people learn about your paper, and at the end probably they will read it and try to cite them. So I think the main message is higher impact in social media probably could correlate with more citations. So to be the social media editor of a journal, it's important. It's a job that needs some care, and it's complex, and many people ask for that. Many people think the last 2 minutes, I have to say that also there are people that probably is more famous about tweets than from citations. That is this Kardashian index. I recommend you to read this paper about that because it's interesting. Other thing that the social media brought to us are the visual extras. In social media, the people share these summaries, and now the people ask for this kind of material. So there is wide publications on that now on social media. So in the main summary, I think it's stay updated. You can make continuous medical education through Twitter. Maybe it's true. The journal clubs is a good example. Case-based learning, it's another option. In Jackie's report, we have a lot of that, and we show advantage of showing cases through social media. You have to be careful with what you publish. You have to have the permission of the patient, not no diffusion of the data of the patient. But I think a lot of people learn with these cases. You can learn new innovation like 3D printing or ITRA for vascular access. The first places were social media. So it's where the innovation is first shared, I think, now. It's a good option for networking and interaction also. You can do polls with the people. And I think these are all the journals, the scientific societies are there. When you know people that it's good to follow because of innovation or people you know on different subjects, these are the people to follow to be updated. I don't know, these are examples from heart failure, for example, in Spain and in English. To summarize my final thoughts, I think I took this from a paper from surgery, but at the end, it's the same value. If you change surgery for cardiology, you have the same message. It's for connecting investigation, knowing relevant scientific questions, the clinical trials, engagement with patients, the knowing how the patients feel, shared information, promotion of your research, getting visibility, and even data investigation. And this is a good summary coming also from Jack on the different aspects that social media could touch in networking, the organizations, education, advocacy, and conference. I think it's a way to stay connected. So I have to end with this. The most important, always try by your own. I think this is the main message that I want to leave. I think you have to go to social media and see if it's something useful for you or not. Thanks for your attention.
Thank you, Dr. Vidal, for the fantastic presentation. Actually, I had read the Kardashian Index paper this year in February, and yeah, it was an interesting paper. I would like to learn your opinion on this, if this Kardashian Index thing exists in cardiology.
Well, I think if you read the paper, mainly there are not so many Kardashian on the cardiology wall. That's the main conclusion. The point is that people that have a lot of influence on social media, but not real influence on the academic wall. This is kind of fighting. You have a lot of people that could read what are you saying, like people or experts, but usually in the academic world, I think the value of the people is the citations of your paper. So they try to correlate this. So you have a lot of followers, but no citations. Probably you are like a speaker, but you don't have many knowledge. Probably few people could. The people that I know that are very active on social media, many of them have a good profile on scientific topics. You can say that Michael Gibson is not a Kardashian because he's a person with a lot of publications, Harvard professor, but he has 100,000 followers, but he has a lot of citations. So even he is not a Kardashian, but he's somebody that many people follow on social media. Or Eric Topol. This is another good example of a lot of followers, but it's one of the most cited people alive. So there are some people that probably could be Kardashian, but in cardiology world, probably there are not so many. Fortunately, I think
and have you? Yes.
Yes.
So I have another question. Have you observed any gender disparities in the in social media users, cardiologists, social media users? Like, can you say that women are underrepresented, or
well, I think
I don't know.
Probably, I have to say that probably if you check with these statistics of general use of social media, it depends on the platform. Probably you have more male than female, but I have to say honestly that there are many active users on cardiology world that are women. So I think it's how to say that. I think it's there is more balance that in the if you check the whole thing of the social media, probably there are more men oriented than female. But I think in the cardiology world there is probably an active proportion of women on social media. Probably in the professional field, not thinking on social media, there are for now not so well represented. But on social media, I think they are very active, and I think they are near to a balance. I think in Spain, for example, 60% of the cardiologists are women. So, but thinking on social media, well, I think it's not so big disbalance, I have to say. Probably there is some disbalance for this technology thing that probably men are more used to that woman, but I think it's something I'll view. I think it's now the engagement is it's different. I think at least I know very active female cardiologists in the Twitter wall. At least I have to say there are a lot of them.
Yeah, I was wondering if there are less female users due to the concerns of being bullied, etc. So that's why I just wanted to learn about your observational ideas.
It could happen, but I think it's in cardiology. I think it's how to say, there is many active people. At least maybe if you go to the numbers, because many people, the problem on Twitter or Facebook, many people is silent. There are a lot of people with an account, but they never tweet or never post something on Facebook. But when they post, I think there is a balance, I think.
And one of our participants say that they have a paper hopefully coming out on how women in cardiology use social media. So yeah, we may learn the statistical details maybe. And Dr. Martins has a question. Yes. First, he thanks you for your great presentation, and then asks about if you have any insights on how to manage all social media accounts, could be LinkedIn, Facebook, Instagram, Twitter, how to manage them at the same time. Is it better to stay with only one social media account, or how to do?
I think probably it's difficult to manage all the things at the same level. I have to be honest. I like more Twitter, there are tools that allows you to manage different social media accounts, to post the same everywhere, but probably it's difficult that the same contents have the same success in all the social media accounts. There is HotSuite, for example. There are more tools, I think, on how to use more social media at the same time. But honestly, probably the people focus on LinkedIn or Twitter. You can have both, but at the end, the people, I think, some people focus on LinkedIn, other people focus on Twitter. I think it depends more or less which people you follow or not. I think there are tools to manage your social media globally. There are solutions that are free. There are solutions that you need to pay to have better uses. But if you are thinking on something professional, probably at the end you focus more on one of the tools than the others. And the people always suggest to publish different things on the different platforms. You can transmit the same message to Instagram than through Twitter, probably because the audience and the language you use is not the same.
Yeah, and also your study published in the European Heart Journal this year, the one you showed during your presentation, the ESC journal study, I guess. So you used the studies that were cited by ESC journals, right?
Yes.
And how does the ESC journals user decide which articles to promote? Is there any criteria by looking at the authors or?
Our idea that we excluded some papers because we know that some papers need to be published. So we excluded guidelines. We excluded also recommendation papers from the different associations. We excluded papers that have a press note. So we went to the papers that are the normal research at the end. Nothing. And we do it randomly. I have one question one day in Twitter about a person. I think it was a good question, because it's like a bias. But if you don't do the study, you don't know the bias, because they say, you are excluding some papers. If I will be the author, I will piss off because you don't promote my paper. But we don't know exactly if promoting a paper gives citations. This is like when you use a placebo. I think after this study, you cannot do that thinking on that if you do the same things in a trial, because you know that promoting something gives citations. So you are, how to say, giving less options to an author, because if you promote a paper, maybe you get more citations. If I am the author and you don't select me to social media promotion, probably I will be unhappy.
Yeah, we should have the preliminary data.
This is a randomized study. It's also the first part of the follow-up. Maybe in 2 years, the effect is not the same. I don't know it, but you have to do it in that way. You choose randomly papers, knowing that we exclude some of them because you know that you have to make the promotion due to, how to say, political or scientific reasons from the European Society. But in the first part, you have to choose. Of course, if I were an author, I don't like not to be tweeted by the, how to say, ESC social media account. That's the point. But it was not created before. It's something that we started to do with the ESC journals account. And we saw that it has the effect that we expected. But that information was not available before.
And I also would like to learn how the ESC journals account decide on promoting a particular paper or not, by looking at the clinical implications of that paper, looking at the messages.
This is the job of the social editors and the editor-in-chief of a journal. I think the things have changed. As sometimes you choose one paper to give it on open access, for example, for some days, or if you, I think it's the, how to say, it's how the editors curate the content of a journal. At the end, you are deciding what you want to highlight. That's I think there are no doubts that if you have a recommendation paper, a consensus paper of a guideline, is of public interest, and everybody must know it. But if your research or not, it's something that probably depends on the likes of the editors, of the social media editor, of if you think that this paper will create engagement, because at the end you have different, how to say, you know that some papers give more discussion than others.
Yeah, sure.
It's like if you think in a newspaper, how you choose what is in the first page. It's the decision of the editor of the newspaper. At the end, it's more or less the same job. That probably has some implications on the on the diffusion of the paper, or how to say, the final reach. Maybe more citations could come because of this public announcement of one paper.
Yeah, okay, yep, that makes sense. Thank you very much, Dr. Vidal-Perez, for your fantastic presentation. And now I'd like to proceed with my own. So I'm now expecting the share screening invitation.
I left mine, now free.
Yep, now I hope you can see my screen.
Yes.
Yes. Now in the next 20 minutes, I will make a brief presentation on the mobile health technologies in cardiac care, of course, from a cardiologist's perspective. Here is the overview of my presentation, what I will cover in the next 20 minutes. So let's start with the definition of mobile health. This was published in Circulation in 2015, and the mobile health is defined as the use of mobile computing and communication technologies for health services and information. And what we refer to as mobile communication and computing technologies are the mobile phones, tablets, and wearable sensors. So I have difficulty with proceeding to the next slides. Oh, yeah. So why has this concept emerged in cardiology? Because cardiovascular disease is the leading cause of mortality, and it's obvious that we need innovative approaches to tackle cardiovascular disease. This slide shows the tremendous effort in looking for the most optimal mobile health technology that could be used in clinical practice in cardiology. And here I try to summarize the main applications of mobile health in cardiology. The first one could be ambulatory monitorization. Second, personalized interventions for health promotion and prevention. Third one, telemedicine. Fourth one, virtual learning platform for medical care professionals. Let's first start with the ambulatory cardiac monitorization. I think as cardiologists, we are very lucky because the variables, the parameters that we are interested in our patients are easy to be monitored or detected by using these ambulatory devices, which include the heart rate, rhythm analysis, blood pressure, pulse oximeter, tracking the physical activity, and the cardiovascular fitness, which we know that using combining all these parameters, creating a multi-parameter system could even help us with the 6 minute walking tests. This slide may seem a bit crowded, but the main message that I'd like to give in here is that there's there are numerous manufacturers producing various types of devices for clinical applications. But as we all know, the most studied topic in this field has been atrial fibrillation. Why atrial fibrillation is so important? Because it's the leading cause of, it's the most common cardiac arrhythmia. And yeah, I cannot pass to the next slide. Yes, atrial fibrillation is the most common heart rhythm disorder and is associated with increased risk of adverse events. And we know that if the disease can be diagnosed early And if appropriate interventions are initiated timely, we can prevent these complications. This slide shows us some examples for the mobile heart rhythm monitors. The first one here you see is a leadless patch ECG monitor. The second one is an investigational smartphone app using the photoplethysmography method to detect the rhythm of the patient. The third one is an FDA-approved wristband, which is used in complementary with a smartwatch, which is an Apple Watch. The fourth one is also an investigational smartwatch. Actually, it all started with the Holter monitorization devices, but they are bulky, and patients have to come visit the outpatient clinics in order to get their data transmitted. But these devices are small and easy to use, and more easy to be implemented in our daily clinical, let's say, patients' lives. So it started in 2012 when AliveCore received the FDA clearance for using that product by a licensed medical professional. The CardioMobile product is the one that I showed you in the previous slide, which is the third one that I'm showing with the arrow right now. And now when we come to 2019, we see that 6-limb device has been introduced, which records all 6 limbs simultaneously. I told you that most of the studies have been focused on heart rhythm detection, and I will give you some examples on the published ones. If I can pass to the next slide, so I'll wait for a couple of seconds. So the first one that I want to mention is the one published in Canadian Journal of Cardiology. It used the CardioMobile ECG device, which was the one I showed you, which the one approved by the FDA. And this study was undertaken among Canadian primary care physicians. Here, the mobile ECG device was compared with the physician-interpreted 12-lead ECGs, and you see high sensitivity and specificity rates for detecting atrial fibrillation. And the second one, again, we have some slow motion while passing the slides, but the second study that we all know was published last year in November, the Apple Heart study. Here, the patients without known AF were enrolled, and they, of course, were using an Apple iPhone. And when they received an irregular pulse notification, an ECG patch was mailed to the participant to be worn for 7 days. And let's move to the next slide. It takes some time. I don't understand why. So it was found that 2,100 participants received that irregular pulse notifications, and 84 of them were concordant with AF. And those patients, these 2,100 patients received 7-day lasting ECG monitoring additionally, and 34% had AF on subsequent ECG patch readings. Another study published this year in January, again, used the same device compared to a 12-lead ECG showing high negative predictive values. This is the MAFA trials using the mobile atrial fibrillation app. The pre-MAFA 2 phase was a pilot study, and the investigators assessed the how useful this app was to detect in the general population to detect AF. And patients that were diagnosed with AF in the pilot trial, plus some other patients from the community, were recruited in the second phase of the trial. And in this trial, patients were randomized to either usual care or mobile atrial fibrillation app usage. And the app allowed an integrated care management using anticoagulation, better symptom management, cardiovascular risk and comorbidity management. And if we can move on to the next slide, you will see that in MAFA-2 trial, the usage of this mobile app resulted in reduced rehospitalization rates and the primary composite event rates. Again, let's wait for a couple of seconds. Yes, This is the MEFA2 trial published just last month at JAC. Integrated care based on the MEFA app was compared with usual care in patients diagnosed with AF, and the patients were followed for a mean of 8 to 10 months. And here you see that compared to the usual care group, the MEFA group had significantly lower risk of rehospitalization and composite outcome of ischemic stroke, thromboembolism, death, and rehospitalization. So let's move on to the second part of the applications of mobile health, which is personalized interventions for health promotion and prevention. As you all know, blood pressure control is one of the most important topics to be covered in cardiovascular disease prevention, since it's one of the most important modifiable risk factors. Here you see a research article published in 2015. The reason why I presented this article in here is that the authors have provided how smartphone-based mobile applications can improve blood pressure control. 72% of the apps had tracking function, 22% had tools to enhance medication adherence, 37% contain general information on hypertension, and 8% contain information on DASH diet. So when we move to the next slide, in a few seconds, we will see that Italian and European Society of Hypertension has proposed an application named ESH Care, which allows blood pressure tracking plus patient and physician interactions. Yep, here you can see the application. And it also allows remote monitoring of hypertensive patients, which is very useful. Physical activity tracking is another important point for a healthier lifestyle. There are several trials that have focused on the use of mobile apps for promoting physical activity and therefore maintaining a healthier life. How does an app be useful for tracking physical activity? It could be through counting the steps, sensing the heart rates, counting the days of exercise, and timing, getting to know the timing of the sitting duration, so that when gathering all this information, the app automatically generates or estimates an energy expenditure. And it also provides some info about the intensity of the exercise. Another very important risk factor in coronary artery disease, is smoking. And this was published in 2011 in Lancet. This was a randomized trial performed in adult smokers, where the patients were randomized to text messaging to promote smoking cessation versus unrelated text messaging. And the text messaging, this included behavioral or motivational text messages, and it resulted in an increased rate of biochemically verified continuous abstinence at 6-month follow-up. So I'm waiting to move on to the next slide. I will mention about medication adherence in the next slide. And it's particularly a problem for the elderly, because there is a problem of amnesia and polypharmacy. So there are many ways of improving the medication adherence, which includes reminders, mobile reminders from smart apps. If we can pass to the next slide. And as I mentioned, mobile reminders is a good idea for managing medication adherence. Plus, it was very interesting for me to learn while preparing this presentation that there are many high-tech methods to improve this, such as medication packages sending electronic signals when they are opened, or pills can emit signals when they enter the acidic environment of the stomach. So I don't know when we will be able to use such technologies in our clinical practice, but they sound very interesting. And this is a Cochrane systematic review conducted in November 2016 regarding medication adherence in secondary prevention patients. And the authors could come up with 7 trials where 1,300 participants were involved. And here the intervention was SMS or MMS compared to no intervention or other models of communication to improve medication adherence. However, the authors concluded that the quality of evidence was very low. This was due to the authors thought that the study population does not reflect the general population, because high-income countries and mostly men were included in the trials. This sounds also very interesting to me. The MICOR trial, which is whose phase 3 trial is still ongoing. This uses digital health platform designed at Johns Hopkins, and it's called CORI. The CORI health platform includes the Apple Care Kids smartphone app, which is complemented with the Apple Watch and the iHealth Bluetooth-enabled blood pressure cuff. And of course, the authors want to know how this technology can improve the secondary prevention measures in these acute MI patients, in patients with acute MI history in their medical history. So by using CORI, the patients may be able to manage their cardiac medications, they may monitor their vital signs, and they may be educated through animated videos or articles, and they can also coordinate their follow-up visits. So yeah, we'll see how the results will be. And the third part of the applications of mobile health in cardiology is telemedicine. And initially, it was introduced to improve access to patients living in rural health environments and those who are underserved by healthcare professionals. But now we know that it's being used for more diverse indications. Although there is substantial cost and time investments required for telemedicine, there are three components which we can see the active use in our clinical practice. First one is telemonitorization, second one teleconsultation, and third one is telerehabilitation. And as the name implies, in telemonitorization, there is the transfer of physiological data through transmission technologies. And when we come to teleconsultation, it's consultation using remote telecommunication system, and for telerehabilitation, it is the same. When we talk about telemedicine, everyone thinks of heart failure patients, and this is because most of them are implanted with cardiac implantable electronic devices, and this enables data transmission in an easier way. And this meta-analysis was performed or published this year and included 29 randomized controlled trials and a total of 11,000 heart failure patients. And when compared to usual care, you see that patients where telemedicine is used, there is a reduced likelihood of all-cause hospitalization, all-cause mortality, and cardiac hospitalization. And this is a very interesting study, again, published this year in February in Circulation Heart Failure. Here you see a multi-sensor monitoring device, and investigators in LINK-AHF study, they investigated if this multi-sensor, wearable multi-sensor could be used to predict HF hospitalizations. And on the next slide, we will see how the system works. When the patient wears this sensor, it may detect the ECG, may do the measurement for skin impedance, skin temperature, and the 3-axis accelerometer derives some data regarding the body posture and movements. So the data collected by the sensor goes to the smartphone or tablet via the Bluetooth technology, and then from the smartphone or tablet, it's transferred to the cloud analytics platform, where the raw data is transferred to heart rate variability, arrhythmia burden, respiratory rate, gross activity, walking, sleep, body tilt, and body posture data. So in the next slide, we will see how these data have been transmitted to clinical follow-up data. So here you can see that patients who received an alert from the wearable sensor are more likely to be hospitalized for AF during the follow-up. And the authors concluded that wearing this sensor could help predicting the preceding, the following subsequent HF hospitalization in advance at a median of 6.5 days. So this may be really useful. And this is another study published, or not published, but presented as a late-breaking clinical trial in HRS meeting this year. And this uses Medtronic BlueSync technology. And the novelty of this study is that patients may use the app that's on their smartphone to transfer the data on their pacemaker or CRT, and the data that they transfer on their smartphones can be transferred automatically to the patient management networks, and the success rate is very high. Virtual visits is a part of telemonitorization, and it's being used frequently. It's been started being used frequently by several cardiology subspecialists, and EP people are the most frequently using ones. And this study, again, was published just a few weeks ago at Heart Rhythm Journal, where the virtual visits conducted in EP outpatient clinics resulted in high physician and patient satisfaction rates. If we come to telerehabilitation, cardiac rehabilitation is very important for secondary prevention in coronary artery disease and heart failure with reduced ejection fraction patients. But we know that the referral rates are very low, and even the patient is referred to the traditional cardiac rehabilitation. They do not participate, and they can. A paper shows that only 50%, only half of them attend the first prescribed session. So telerehabilitation may be a possibility to increase the adherence or referral rates, particularly in those that are unable to access the facility, or maybe the elderly. So that's why in the next slide, I will give you the names of some ongoing trials, particularly in the elderly, testing the efficacy of the telerehabilitation system. And the fourth application that I want to mention you regarding the mobile health applications in cardiology is it may constitute as a virtual learning platform for medical care professionals. And we know that these platforms may improve all healthcare professionals' knowledge, including physicians, nurses, and the others. This is a quick study published last year in the European Journal of Cardiovascular Nursing, and it was aimed to improve the knowledge of atrial fibrillation and anticoagulation in nurses. So on the next slide, I will be showing you how the app is working. There will be 3 screenshots, so it's a bit slow. Yes, here when the nurse, the person enters the medications and the presentation findings, PE presentation findings, the person may get to know the patient's CHADS-VASc score, and then learn about the how to medically manage the patient. Of course, this is particularly important for the anticoagulation strategies. And here is the app proposed by ESC. This is the healthcare professional app, which is named AF Manager, and MyAF is the version for the patients. So we now have a brief knowledge on the mobile health applications in cardiology, but how do the patients think about this? This was published last year in European Journal of Preventive Cardiology. A survey was conducted in 300 patients with cardiac implantable electronic devices, and the survey was about their expectations. On the next slide, we will see some results from this study. And here you can see that the patients are interested in receiving device alerts because they want to know if their device are functioning correctly, how about the battery life, etc. But we see that they're not very much interested in receiving healthy lifestyle advice from their mobile devices. And the same applies for the medication adherence advice as well. We will see here that that they are not much interested in regular reminders for medication intake, but they mentioned that they would like to have a possibility to have direct contact with their healthcare provider, and this shows that they are more interested in face-to-face interactions. Another study published last year, this also assesses the prevalence of mobile health access and usage in patients, subjects with coronary artery disease or those at risk for coronary artery disease. This study was conducted in around 3,200 patients. On the next slide, we will see the results. So here you see that most of the patients actually have access to mobile health. They own smartphone, own tablets, or can use the mobile healthcare apps. But as you may see in here, there's a sharp decline in their wish to use their mobile health devices for tracking health progress or making health decisions. These are the patient perspectives, but I still believe that in the next years, there will be an increasing utilization of these mobile health technologies, mostly because the population is aging and they will have impeded mobility, and the shortage of physicians and nurses may occur to cover the increasing needs of the aging population. And larger territories covered by wireless network that allows accessibility again may increase the utility. But there are still some barriers for the mobile health in cardiology. And on the next slide, I will mention you about the 4 main reasons of the barriers. First one, if we can be able to see, yes, the first one is due to lack of patient motivation and digital health literacy skills. This is mostly due to demographic disparities due to age, gender, or low socioeconomic status, low educational status, and there is disbelief among healthcare providers regarding digital care. And there are legal and technical barriers which consists of regarding data privacy, security, and transparency. And of course, most of the technologies are still not being reimbursed. Therefore, ESC, E-Cardiology Working Group, AHA, ACC, and also FDA, they're all working collaboratively to address these barriers. But how to do that? In order to overcome the barrier regarding patient barrier, there should be patient digital health education platforms. And for physician barriers, contemporary workflow models should be redesigned. And when we come to security, data privacy issues, there should be not only European-wide, but globally digital health certification systems, and it should be the compliance to applicable direct health directives should be assured. And when we think about the economical barriers, we should inform the health insurance industries and policymakers to make improvements, and economical evaluations of the digital health-based care should be encouraged. So having said that, I come to the end of my presentation. I hope you now all have a general idea on the use of mobile health technologies. Thank you for your attention. And now, yes, I will have a look at the comments. Yes, Dr. Duygu has said that they are developing a wristband with AI technology for detection of AF over 65 years old population. It will be available soon for elderly in Turkey. Wow, that's great. Innovation company initially proposed to develop something to detect myocardial ischemia. So this is a wristband, and the company, so this is something separate than the wristband, right?
Yeah, exactly.
Okay. No, I haven't read anything on myocardial ischemia. The ECG monitorization focuses on discriminating AF versus sinus rhythm or non-classified rhythm, but they don't include any ST segment changes or T-wave changes. Maybe this is to my own knowledge, but I haven't encountered any data, any research paper focusing on myocardial changes. But this sounds interesting. Actually, it could be further checked on PubMed. So yeah, telehealth, telemonitorization has been very important in the COVID area. What should be the limits? Should we prefer just some control visits? Should we prescribe medicine? I think in general, telemonitorization should still be reserved to vulnerable patients or any emergent cases like we experienced with the COVID-19 area. I think the ambulatory patients still should be coming to outpatient clinic visits, because I still believe that face-to-face interaction is more important. But elderly people, those who are not able to access hospitals, people living in the rural areas that cannot reach specific specialists, I think telemonitorization is a great opportunity for them. And we can do by using, if we have the infrastructure for that, we can even do the physical examination of these patients using telemonitorization. If they go to any general practitioner, if there's the infrastructure developed in their systems, they can transfer the blood pressure or let's say any vital sign data, transfer the ECG data, and when we open our monitors, we can get the basic data that we need, but it could be just without the physical examination, let's say respiratory system, cardiovascular system examination data, but it still may help with managing the patients. So very risky to prescribe, but another another participant from cardiac surgery, Dr. Basil, has asked, very risky to prescribe, I mean, for medical legal issues. In USA, they started private practice by telemedicine, but all supported by certain authorities. I guess we need the support of local authorities. Yeah, definitely. These necessitate infrastructures and legal permissions to be got first. Thank you. I'd like to learn if you have any other questions. If not, I will be, we are coming to the end of this session, and I hope this was useful for all the participants. And I would like to thank our audience for their participation, and I would like to meet you in future meetings. So yeah, good night, everyone.